So, as you know, AI is increasingly getting into healthcare, revolutionizing the healthcare outcome. And predictive analytics, along with harnessing data and advanced algorithm, healthcare providers can now predict the patient outcome and we can optimize the care delivery. As per the studies, 80% of the healthcare executives believe that AI driven outcomes, predictive analytics, will improve patient outcome and operational efficiency in coming years, say by 2025. Hello, everyone. I'm Nilesh Maheshwari, founder of Healthcare Health, and I welcome you all to the new episode of my podcast, Healthcare Musings with Nilesh. So, as you know, AI is increasingly getting into healthcare, revolutionizing the healthcare outcomes. And predictive analytics, along with harnessing data and advanced algorithm, healthcare providers can now predict the patient outcome and we can optimize the care delivery. As per the studies, 80% of the healthcare executives believe that AI driven outcomes, predictive analytics, will improve patient outcomes and operational efficiencies in coming years, say by 2025. So, there is no doubt that predictive analytics in healthcare has a significant role to play. And to discuss all about healthcare predictive analytics, I have Paulo Pinho, Chief Medical Officer at Discern Health. Welcome, Paulo, and could you please introduce yourself to the audience?
Yeah, hi Nilesh. Thanks for having me. My name is Paulo Pinho. I'm a physician by background. Practiced full time for about 15 years before coming out to more physician executive roles. My interest in healthcare analytics really started in the data standards world. And so I worked with clinical data standards, the HL7 community, traditional vocabularies, etc. And at that point, it was really how to make the data usable for consumption and to drive insights in healthcare. I've now moved into the predictive analytics space. I work for a company called Discern Health, and basically what we do is we take clinical claims, social data, various data sets, bring them all together to provide insights on health outcomes in the most vulnerable populations. So great to be here and looking to dig in deeply here.
Excellent, excellent. So, Paulo, where do you think is the what is the status of predictive analytics in healthcare, and where are we heading towards?
Yeah, so I mean, I think there's a lot of opportunities, and in terms of AI and using AI in various disciplines, I'd say the last year has really kind of accelerated. There's a lot of hype, large language models, et cetera. And I think we're kind of facing a challenge in healthcare where the population is aging, it's becoming more complex. There's more of an onus to really provide personalized care. And at least in the United States, what we're experiencing too is a shrinking provider community. It's not just physicians, NPs, and PAs, but it's respiratory therapists and nurses, and a whole host of other disciplines. And so, in order to scale and to sort of mitigate some of those challenges, we need to look in sort of non-traditional directions. I've used the example before. The stethoscope had challenged adoptions when it first came out. It required somebody to sort of have a leap of faith and understand that, hey, they're putting this cold metal on someone's chest, and listening to sounds that are unique to them, and all of this was new, and it took some time before there was adoption, but eventually there was. Do I think that this is going to replace any of the current human element that exists in healthcare? I don't think so. I think what it's going to do is it's going to supplement and provide another tool that could be game changing in the armamentarium of medical provider to help provide that sort of personalized care to those populations that are becoming more medically complex. So now's the time, and I think that it's a question of engagement. Kicking the tires on solutions, validating that they are providing things that are not black box and they're ethically provided, And I think if we do that, this could be a real good opportunity for the healthcare industry.
Okay. Yeah. But what are the some misconceptions about predictive analytics in healthcare?
Yeah, so I think some of the ones that I hear more regularly is that the logic that's used in some of the models that we're building is similar to sort of the logic that a clinician would use. There is humanity in predictive analytics and AI, and it's sort of the goal is to kind of mimic thought process and mimic decision making as a human would do. In terms of that human in the loop is really important. So I think the fear that you know machines will replace humans is probably a thing that I hear a lot. And I think that if you're going to do it thoughtfully, you need to have a human in the loop all the way. Um, they need to, identify the problem, build sort of the feature set, or assistedly build the feature set, and then ultimately identify that the solution actually has a home that can be impactful. So I think that's a big issue. So I don't think this is obsolescence for a human being. I think this is more opportunities for human beings to redefine their jobs, and I think that that's probably the biggest misconception. In terms of this is not the goal of this is not to diagnose. The goal of this is not to, um, replace human thought. The goal of this is really around how can we use this to supplement and allow those most skilled people in healthcare at all disciplines within the healthcare ecosystem to really work at the top of their license. I think that's a misconception that's common. Hallucinations do exist. There are ethical frameworks that we need to build these on. And there is bias that's injected into all kind of predictive models, and so I think that if you're a responsible AI predictive analytics company, you're really looking at how do I test this on various different populations that have various different information and sort of features within them, so that I'm not overfitting this to one population that may not be representative of a larger whole, right? Or one population that may not be like another one. And so I think there's this belief overall that here's this cowboy technology that's going to replace all of our jobs. I think that it's a very human guided technology that's going to be very assistive and very influential in the way we practice medicine, as we move forward, especially with the data onslaught and the increasing technology that we're seeing in healthcare.
Right, rightly said. And I think the AI and the new technologies are going to actually expand the human potential. What a human being can do beyond, over and beyond. And I think this will help in reaching out to the patients who cannot afford it, or it is not accessible to people, to a
Yeah.
lot of people. And it can also help, in a lot of developing or underdeveloped countries where
Yeah.
there is scarcity of resources, providers, medicine, diagnostic tools, etc. I think applying some of these technologies and expanding the potential of the limited set of resources, I think that will be beneficial to everyone, all human beings. And so this is not going to actually replace the human touch, but I think it will expand the human potential.
I agree. I mean, I think you bring up a good point. I think reaching some of the most medically vulnerable in medically vulnerable areas, um, there's a challenge of resourcing, right? I think that this provides a scale and a consistency too, right?
Systems.
I
Yeah.
think that the one of the issues of human engagement is that there is inconsistency, right? And there's bias involved in every decision making. I think if you're thoughtful about this, you can make this so that you're really evaluating the bias on a case by case basis. You're really providing it to the greatest number. Yeah, I mean, I couldn't agree more. And especially I think the other thing is we look at costs and we look at allocation of resources within our healthcare ecosystem here, and I even think around the world, there's a lot of waste. There's a lot of sort of low value care, misdirected care. Um, there's a lot of guesswork that's involved, and sometimes spending a lot of money to not get the outcomes that we want. I think that deploying, these solutions, for the right audience, with the right clinical intent, with the right metrics that are not operational but really premised on outcomes. I think right sizes a lot for our healthcare ecosystem. There's a data that I read recently that and you mentioned earlier about sort of the belief that predictive analytics and AI will sort of expand. I think where it's going to expand is in the clinical and public health domains considerably. And there's actually a statistic that I read recently that there is also belief that a quarter, if not a third, of all healthcare waste, fraud, and abuse, with just a very low lift, could be eliminated by predictive analytics. And that's not even talking about the 2/3 of our healthcare spend that's actually not wasteful and not fraudulent, stuff like that. So there's really a lot of opportunity here to really make a significant dent on how we spend in healthcare and how we thoughtfully spend in healthcare.
Yeah, and I think you have mentioned one very important point, that it is going to be repeatable and consistent.
Yep.
Because it will not be the AI will not be a moody kind of a person, because today I'm not in a good mood, so I may not be treating the patient the way I used to do it when I'm in a good mood. So it will be repeatable, consistent, and I think that is the beauty of this the technology. So can you share some real world examples where the predictive analytics has significantly improved the patient outcome?
Yeah, so I mean, we have a myriad of models. We have 5 different model classes, and really focused on kind of significant challenges in the healthcare space from a cost standpoint, and from not only financial cost but also a cost burden to the families, emotional burden, et cetera. So probably our earliest model that we currently have piloting right now is actually it's a falls risk model. So what it's doing is it's actually taking clinical claims and social data, and it's using those in interaction to kind of identify who in a population is likely to fall within the next year. And it's based on evidence basis. Again, there is no black box answer. It's not like, if the person lives on a street that begins with the letter A and the second number in their, address is the number 2, they're going to fall. This is, what are the things that a clinician may not be able to see in the 7 minutes that they're seeing a patient, or a care manager may not be able to see because of the fact that they have an expansive list of patients on their panel, that really come to the level of, this is a sum total where this person's risk is exceeded that, more than flipping a coin, right? And so, we're getting about 0.85 AUC, on that model. It's designed to actually, it's got a great negative predictive value. In terms of the positive predictive value, we can't, obviously take into consideration things like misadventure. Somebody decides that they're going to get on a ladder. That's not something that we would have been able to predict. But in terms of those people that are experiencing clinical decline and converging on falls, it is accurate in terms of predicting that. And so if you look at what a fall costs, it's about $10,000 if it's an outpatient fall, up to $20,000 if it's an inpatient fall. And that doesn't even consider the non-direct costs associated with that, pulmonary embolus, and et cetera, et cetera. And so the cost of intervention is usually very low, less than $1,000. And so if you can get those true positives appropriately, you now intervene for less than $1,000, and ultimately stand to save up to $20,000 on these more complex falls. The features are probably features that any clinician will be able to identify, right? It's things like hey, they're having issues with sight and hearing, and they're having issues related to medical management. So all of the things kind of converge to really paint a picture of risk for an individual. So that's one example. And I think that benefits, like I said before, medical providers who take care of geriatric and complex patients. This takes care of a lot of the care management issues. Even there's government initiatives like the CDC has a whole initiative around fall risk prevention, in that population. We also have models that focus on cognitive decline, identifying who's at risk for cognitive decline. They can predict the likelihood of memory impairment significantly earlier than a clinician would document that and get people on the right journey. And healthcare takes a village, and so this is not only focused on payers and providers and life sciences companies, but there's a big opportunity in the long-term care space. Long-term care insurance is a type of insurance that really deals with this sort of morbidity element. Mental neuro is a big reason why there is claim. Oftentimes, there's not a lot of insight and granularity on outcomes and who's at risk in that population. And long-term care is going to be responsible for decompressing some of our Medicare spend that's really outpacing projection, right? And so here's a financial tool that exists in the life insurance type industry that now is potentially some way that's going to mitigate our health spend for the future. This is a way to right size that. So those are two clinical examples in terms of utilization examples. Predicting things like admission, all-cause readmission, cause-specific readmission, ER visits, et cetera. Those are other things that we're kind of working on as well, from a utilization standpoint that we have currently in pilots. So, that's kind of some really good early success stories for an early company. So excited to dig in more and continue to find great use cases for clients.
Right. So, what are the main challenges you face in integrating different sets of data like clinical claims or social data?
Yeah, so there's kind of a saying that clinical data, social data, has the challenges of all the 5 V's. So we're increasing the amount of data on a regular basis. So there's the volume of data that's involved in sort of this big data analytics. Medical data is is astronomical increased. Data supports that it's 1,000% over a very short amount of time in the last 5 or so years. The speed at which data comes, or the velocity at which data comes, is a significant challenge. In terms of there's the value of the data. We get a lot of data that has a lot of noise. If you look at claims data alone, claims data has some value, but the challenge is that claims data is documented for the purpose of billing and for the purpose of coding, so that reimbursement happens. It's more of an administrative type data, and you could have things that are not present in claims data that were present in clinical data that you really need to tap into. There's also different drivers for provider documentation and for what they put in claims. Things like medical legal risk, things like patient satisfaction. Obviously making sure that they get reimbursed. So there's drivers and incentives to what exists in claims data, in addition to a delay that challenges its value. I think the variety of clinical and claims data is a challenge. We have multiple different EHR platforms, multiple different, billing platforms. Different organizations use different platforms to represent their data. That variety creates some challenges. And the last thing is, veracity of data, right? And so, what is the truth behind the data that's there? Are we getting the full picture? Particularly some populations that may be more marginalized, right? What is the documentation pattern of a provider who works in an affluent suburban neighborhood as compared to, a provider who works in a poor, kind of more socially marginalized neighborhood? The relationship between provider and patient, on one side is much greater than it is on the other side, right? And so there's a consistency that's there. And so can we trust all the data consistently in every episode of care for every patient? And that's, I think, the last V, which is the veracity. And so I think those are the challenges with sort of harnessing all of this potential data and using it in a way that's contextual that really organizations need to solve. And it's not just us doing it. We have partners that we're working with that are really, not only helping structure some of the data, but then, there's a lot of richness that exists in data that's unstructured, that, you need to extract out so that you have all the nuances of that care delivery and the outcomes that's associated with that patient.
Okay. So, do you see challenges in the quality of data, and how do you ensure that?
For sure. Yeah. I mean, there are definite challenges. And I think, the 5 Vs are probably the greatest representation of challenges. In terms of ensuring it, I think, that really gets back to the medical oversight, concept. And, also having sort of an internal testing mechanism for, the data representation, the data utilization and models, and the outcomes of models. This is where I think the human being comes in and shines, because you're really testing that and making sure that you're not biasing, and not leaving a blind spot because of the fact that the data is there. And then you're also, by the way, over testing it to make sure that if you do see an outcome, that it's causally related to the features that you've selected and not necessarily some mere correlation, right? You could say that someone who has, who's visiting a cardiologist has a higher likelihood of, developing congestive heart failure, right? That's kind of a correlation. I would be hard pressed to wait until somebody gets to see a cardiologist before intervening. You want to get that person before they even get referred, right? And so, as you're looking at the data, you really have to, I think, understand types of data, make sure that there's standardization, make sure that there's causation. If you're going to publish these outcomes of these predictive models.
So now AI is everywhere, like in all parts of healthcare and in every practice of healthcare. So have you run into any ethical concerns around AI in predictive analytics?
Yeah, I mean, there are definite, ethical concerns. And I think, I will tell you, before I kind of launch into the ethical concerns, I did a presentation probably, about a year ago, where I used an AI-driven headshot creator. And I think I ended up getting something like, 100 different headshots, from a couple different creators. The two that were good were fantastic, probably the best headshots I've ever had. The 98 that were bad were bad. I mean, I had misplaced, facial features and and things like that. So there is some answers that come out of AI that are not necessarily appropriate, and that's something that comes with tuning. I think the ethical issues really stem around bias. For me, how do you prevent AI? We talked about deploying it in the third world and really using it to drive scale. How do we ensure that when we're building AI models for that population, that we're not fitting that into a population that's not a third world population, and not addressing the issues that are most important to that population? And so, I think that there's already haves and have-nots in the in the world socially when it comes to healthcare delivery. Sadly, that's the case in the United States. I mean, you look at some of the poorer areas and some of the more socially marginalized. Every health metric is challenged there. I mean, life expectancy in some urban environments in some zip codes is as low as 65 years of age, right, in the United States, right? And then you have contiguous areas where it's 82 or something like that. You want to make sure that you're identifying the things for that population and you're not injecting the human bias that's going to further lead to their social, access issues. And I think the ethical issues too really are, if you're going to deploy this, and it's going to benefit broad population health, it needs to be accessible to everybody, right? And making sure that it's accessible to everybody is, I think, a huge issue. We don't want to create the issues that we currently have in healthcare, where you could take two diabetics in two different zip codes, that have different socioeconomic and social factors, and have completely disparate outcomes. You want to make that's right sized. So yeah, I think the ethical challenge of bias is probably the biggest one, and something that we all need to tackle together. And it really involves ethical organizations. I think having podcasts like this to kind of speak to that, so that you do have clinicians and data scientists that are involved in that. And I think that having patients who are at the crosshairs of some of this social marginalization, some of the social drivers of healthcare, their voice needs to be heard as well, and so including them on panels, and including them in decision making as well.
So now let's talk about preventive care. So have you seen a major impact of AI or predictive AI in the preventive care space?
Yeah, I mean, I think it's early, but in terms of places where it definitely is already started to make an impact, and will undoubtedly continue to make an impact, is really around identifying risk appropriate screening for individuals. I think we do a great job, in the healthcare space, of identifying, who needs their mammography, who needs their colonoscopy, who needs their EKGs, et cetera. And for average risk, we do great. But not everybody's average risk, right? And somebody's average may be different than someone else's average, right? And so I think identifying and using, AI at the point of care to sort of nudge providers to say, hey, this is a person who's missing the following things, based on their overall risk profile. This is someone that could be, it could be hugely beneficial to do this. I also think that, as you look at the volume of data that's coming from genetic and epigenetic markers, that's something that it's going to be a challenge for a human being to sift through, and be able to kind of identify, impact. If we're looking to sort of right size, preventive care, it requires us to look at things like, and by the way, it involves also an ethical framework. Look at things like genetics, epigenetics, metabolomics, proteomics, all these omics that have kind of come out, and really have an overarching predictive sort of process that identifies these issues. I also think that as you're looking at identifying, like I look at diabetic, for example. Most type 2 diabetics are diagnosed 10 years after they initially sort of flip the switch and become a diabetic. Could we use more regularly at the point of care, AI and such tools, to help providers sort of begin that screening process a little earlier, so that we're not getting people at the time that they start having thirst and frequency of urination and increased appetite, really bringing these on before symptoms kind of come up. And in terms of prevention, I kind of mentioned some of the stuff that we're working on. I think there are diseases, there are clinical concepts like falls that being able to sort of identify that they're going to happen because someone's becoming more frail, or someone's on too many medications, or someone has vision issues, or someone's house is not correct in terms of the way it's set up, and there's a lot of clutter. Those are all things that are, I think, important to identify. I think in terms of disease states like the cognitive space, while we may not be able to necessarily prevent progression to cognitive decline, or completely eliminate it, we can certainly delay it. And so that people have better quality of life, and so that we're not solving only for lifespan, but we're solving for health span in people with chronic illnesses as well. So I think there's a lot that can be done here, and a lot that's already being done. I think it's the one challenge that I would also address is that clinicians are very comfortable with their own probabilism. When I see a patient and, I have, a diagnosis I'm making, I don't say, with 100% certainty, this is the diagnosis, right? I say, well, let's look at the probabilities. This is a 75-year-old male with known history of hypertension, with known history of family history. He's on an aspirin. He's on a medication for cholesterol. He's had 2 previous heart attacks, and now he presents with chest pain. What is this going to be? I'm thinking cardiovascular right from the get-go based on his history, but I'm not discrediting all the other possibilities, right? That's kind of the way AI models are designed to work if done correctly. They'll nudge and they'll provide sort of the same probabilism that exists. I think clinicians are comfortable with their own probabilism. They aren't comfortable with probabilism that's created by someone else or by a machine, right? And so part of that adoption is really, I think, a change management and getting them to understand that this is an assistance, and probably going to jog their brain for a couple of diagnoses that they otherwise wouldn't have thought of. So there's even preventive value that's driven there. So I see a lot of potential and things moving in the right direction to get us there.
So, have you seen that the providers are feeling comfortable using AI in their day-to-day decision making or day-to-day meeting with patients?
Yeah, I mean, so I think the if you look at the circles that you and I hang out in, I think we're seeing a lot of forward thinking providers that are willing to think outside the box. If you look at forward thinking, medical schools and training programs, they're starting to incorporate informatics into the way they work, and so there is. However, even that's not one size fits all, right? And you could have a forward-thinking provider in our circle, and then you have sort of other providers that are concerned with the hype and want to kind of be the sole decision maker. And I think that's human nature, right? And you have some training programs in some medical schools that are just not on that curve to kind of start to adopt. And again, this is a social issue. Like I'm very close to an organization in Haiti. This is within our hemisphere here in the United States. I think there's probably very limited education about the use of AI in that medical school, in medical school in Port-au-Prince. And I can tell you, I have a colleague that probably never was exposed to AI at the level that I've been exposed to AI, who did a training program there. So adoption is really there's a lot of reasons behind it. Education is a big piece, training is a big piece, and an individual comfort level. So I think our crew of docs, like the people that are probably going to listen to this podcast are probably, ahead of the curve and early adopters, and if not fast followers, right? But I think there's a lot of other people that are just not on that curve yet, and it's going to take some time to get there.
I think it is a matter of time. People will definitely fall in line and start adopting it sooner or later.
Yep. And what cardiologist and listen, and it goes in waves. What cardiologist 25 years ago didn't have a stethoscope, everywhere they walked, right? And now, it's still used, and the purists, will still spend it. I have colleagues of mine in the cardiology space that say, I get there's predictive value to AI in reading EKGs. There's things that we see in EKGs with AI that we don't see with the naked eye. And that's a trained cardiologist. Same thing with a stethoscope. You look at cardiac imaging and what's happened with that. Sometimes the stethoscope ends up just being a motion, right? Because you're going to do that echo anyways, or you're going to do that, like that more invasive cardiac test that's going to provide so much more data. I think AI is the same thing, right? It's really getting comfortable with saying, hey, I know the stethoscope still has a value, and I don't never want to throw mine away, but maybe it needs to be an enhanced stethoscope that also has other features that are able to kind of correlate sound waves with EKG tracings, and really provide insight there. Or maybe it's we're going to use this, but it's a stepping stone to an echo, that we're looking at this particular valve because that's what we're hearing. We've just gotten so much better at that, and I think AI is going to do the same thing.
Yeah, definitely. I think a few years back we worked on a project which is similarly using the sound waves from the human skull, and then based on those sound waves and the frequency and the spectrum spread and the energy in different frequency zone, we can we created a model which machine learning model which can predict if the patient is migraine patient or an early symptoms of migraine, or can have migraine in some few months or later in the year. So that's something we have done, and I think that was pre chat gpt time, like 2 years back. But now I think with the technology evolving very fast, and a lot of models, a lot of prediction coming in, with the power of technology as well as the power of computing, the hardware, I think we can future is like very fast changing in terms of predicting through the stethoscope. Maybe we will have something which is very advanced stethoscope which may predict something phenomenal.
Yeah.
uh, so do you have any ideas on where the future is going, like any future trends or the tips on the AI side?
Yeah. I mean, I think that, if you look at, uh, just look at some of the sort of challenges that I've described in terms of, population aging, the onslaught of medical know-how, and, like what, genomics and all these omics are doing to sort of revolutionize the amount of data that flows in. You look at how connected people are, with sort of the Internet of Things. And, I have a bunch of wearables, that sort of address everything from my ability to meditate to my sleep wake cycle, and can even nudge me when I've had too much caffeine. And, and I get to, gamify my exercise so that I feel good about myself, and can see that I beat colleagues. There's a lot of data that we're going to need to look at, and there's not enough time in a provider's day to look at all that data. Forget about just even the data in the electronic health record, right? Which is, at the point of care. But now all of a sudden, wearables are predicting atrial fibrillation, and sleep disorders, and, fall risk, and accelerometers are, identifying, unsteady gait patterns and things like that. There's a lot of that information that could be really valuable. And keep in mind that, care in the United States and many other places in the world is episodic, right? And so we need to go to our provider when we get sick so that they can take care of us and make us better, right? What if you can, sort of harness all that data that comes from all these different patterns, and really start to be preventive, instead of that patient saying, "Hey, I'm not feeling good, so I'm going to go to the doc." A solution that's really continuously collecting data, remote patient monitoring, et cetera, nudges the patient to say, "Hey, in about 2 days, you're not going to be feeling good, and you're going to need to go to the doc. So go now," right? And so I think that's a future state. I mean, you're starting to see conversations about things like hospital at home. You're starting to see the fact that, caregivers aren't going to necessarily only be physicians, nurses, nurse practitioners, PAs, paramedics, EMTs, respiratory therapists. We're going to depend much more on family members to be, caregivers, and to be the initial eyes and ears for a patient. I think drug design is going to be, become tailored to individuals based on, AI needs. I think that, accessing clinical data is going to happen in a way that, you can look at large swaths of a population and identify very specific information using things like large language models on these. I think that the ability to sort of, detect documentation patterns in clinical data and identify everything from utilization patterns to, clinical decline to fraud, waste, and abuse, et cetera, is going to be greater. I think it's really, let's solve, in this adoption, we need to get physicians comfortable with the adoption by maybe decompressing them from some of their current burden, right? I mean, I look at how providers document. Providers spend, I mean, I've heard stats that range from, up to a quarter, up to a half. I read a recent stat that says that for every hour of patient care, they spend 2 hours clinically documenting. Most clinicians are documenting for 2 hours at home. They, leave the office. We know that there's significant physician burnout and provider burnout post-COVID. I only think that that's gotten worse. These are administrative challenges that exist, and you have to have patients comfortable. I mean, I remember I had when I was working at a job, I had a scribe. Many of them were really good. Many of them had clinical acumen, but they didn't document the way I document. And so even though I had somebody that was supposed to be my eyes and ears in the room, um, and they would ask me the right questions, when I went back at the end of the day, I wasn't just rubber stamping those notes. I wanted to make sure it was really cataloging what happened with that particular patient. And so, it requires people to get comfortable with a new workflow, and adoption strategies are important. But I do think that there is a role to play as we try to right size, healthcare for 300 million people in the United States. Pandemic response. How can we use AI to identify pockets of access issues, pockets of marginalization issues, and make sure that we're doing the preventive strategies to prevent them from getting sicker? How do we make it so one population doesn't have higher hospitalization rates, higher deaths, et cetera? All of this is the possibility for the future. And I think it helps us, I think the pandemic really challenged people's belief in science. I think that there's an opportunity with AI, predictive modeling, to start to reclaim some of that faith that needs to exist in order to solidify that provider-patient relationship and that consumer relationship with that healthcare utilizer for the broader healthcare ecosystem.
So we are reaching to the end of our podcast. So any final advice for the practitioners, providers who are looking forward to integrating AI or predictive analytics in their day-to-day practice?
Yeah, I mean, I think it requires sort of turning off the old way of doing things and being comfortable. When you dip into the ocean, at least in New Jersey where I am, and especially at the early part of the summer, taking the plunge is a bit of a challenge. You want to wet your feet and go into your knees and then keep progressing in slowly. I think it's worth testing. I also think that there's various different ways to say this. There's like anyone. I've heard a couple of different quotes along this line. Anyone that is worried about being replaced by machines probably should be is one way that quote comes out. And I think a more appropriate way of saying that is I don't think that machines are going to replace clinicians. I think clinicians who are comfortable with machines are going to replace clinicians who are not, right? That was the case with EHR adoption. I'm sure that was the case, and I wasn't around it with stethoscope adoption, right? If you're a cardiologist and you were using a pulse and putting your ear on someone's chest, you quickly got replaced by the guy who had the neat new toy. And so I think in order to be in order to not be that person, look, one of the most game-changing things that I've done in my career is really learn about informatics and kind of advance my education. All of us in clinical practice are lifelong learners. Don't hide behind the mystique. Go out and take a course in predictive modeling. Go out and take a course in basic data science. I think that's only going to accelerate your career, your adoption, and your ability to provide the best care for your patients. So I think that's sort of the best way to kind of close here.
Definitely, and that was a very interesting conversation with you, Paulo. And thanks for being at my show. And I hope all the viewers got a great insight on the AI analytics, predictive analytics, and how it is changing the healthcare systems. So thank you, Paulo. And
Thanks, Nilesh.
to everyone, you have a great day ahead. Thank you.